Good evening, everyone. I'm Dr. Vaishali Gupte, Director Medical at Cipla, and it gives me great pleasure to welcome you to this webcast on Baricitinib in COVID-19 and unmet need fulfilled. The second surge of COVID-19 has impacted us immensely, and many drugs have been repurposed for the treatment of COVID-19. Baricitinib is one such drug recently approved for emergency use in treatment of COVID-19. Objective of today's webcast is to discuss on evidences so far and clinical experience surrounding its use. We are extremely honored to have eminent faculty members for this discussion today. We have with us Dr. Yatin Mehta sir as our esteemed moderator. He is a chairman at Institute of Critical Care and Anesthesiology, Medanta Hospital, Gurgaon. I thank him for accepting our invitation. Our esteemed panelists are Dr. Sanjay sir. He is a consultant critical care and head intensive care at SL Raheja Hospital, Mumbai. Dr. Anup Warrier sir. He is a consultant at Department of Infectious Disease and Hospital Infection Control at Eastern Medicity, Kochi. Dr. Reshu Gupta ma'am, she's a senior consultant and HOD of critical care at Department of Health City Hospital, Guwahati. I really thank all of them for accepting our invitation. It's a great honor to have these eminent faculty members for this discussion today. With this brief introduction, I hand over session to Dr. Yatin Mehta sir to take it ahead from here. Thank you so much.
Thank you, Vaishali. Thank you, Cipla, for organizing this. Pleasure to be here. Okay, you people can see the slides?
Yes, sir. Can see.
Okay. So I'll just talk in short for Baricitinib and then I'll hand over to the other two speakers. I bring you greetings from Medanta, outskirts of New Delhi, large tertiary care hospital with more than 200 ICU beds. So this is how I'm going to cover in the next 10 minutes or so. As we all see, we were just discussing, I and Sanjith were discussing how the cases are slightly going up different parts of India. And you can see large number of almost more than 40 crore have been vaccinated, at least one shot in India. But still, some parts of India, the cases are going up. Coming to the management of COVID-19, this is a classic diagram which all postgraduates should know about. That initially there's a viremic phase. From the upper respiratory tract, you go to the lower respiratory tract. There will be mild constitutional symptoms. And that is where drugs like favipiravir or ivermectin were used. Doxy, we used it quite a lot initially. Then you come the pulmonary phase, that is phase A and phase 2, where the hypoxemia progressively gets worse. And then it progresses to ARDS, where cytokine release syndrome is also there, and different multi-organ failure will happen. So this is the therapies, how they have progressed. In the phase 2 and 3, you can give remdesivir and convalescent plasma was used. Now it is not being used anymore. We do use steroids for these patients. IVIG was used, tocilizumab or other IL-6 inhibitors, and then finally JAK inhibitors came into play. So as I said that we had cytokine release syndrome, another 5-7 days of beginning of the COVID illness. And the cytokines are released not only from endothelium, but also from activated macrophages and monocytes and lymphocytes and K cells and dendritic cells. And this was in earlier days. We had published a cytokine storm review article in COVID-19 specifically, where we did discuss the different therapies available. And as I talked about, that COVID-19 triggers recruitment of these cells which release the cytokines, both pro and anti-inflammatory. That's where cytokines activate through the JAK and STAT cascade is activated, which is where the JAK receptor inhibitors can work. So these are which inhibit the cytokine release. Baricitinib and tofacitinib are approved by FDA for treatment of rheumatoid arthritis and dermatitis. So specifically, baricitinib is more effective against JAK1 and JAK2. So the STAT signaling, signal transduction and translation signaling leads to gene expression and multiplication of the virus. which is what is blocked by this thing. So it's a small molecule, selectively inhibits reversibly JAK1 and JAK2 with very little effect on JAK3. It has an antiviral effect. It's been used for rheumatoid arthritis, and it is a very safe drug. So this is what it shows, that it blocks the STAT phosphorylation through JAK of STAT mechanism, and therefore the viral replication is inhibited. So viral entry is also endocytosis of the virus, because it blocks this AAK1 and GAK transport entry. It impedes that. So viral entry is also, endocytosis is inhibited by this drug. As I said, atopic dermatitis, rheumatoid arthritis was approved. Emergency use, it has been approved for use in combination with remdesivir for treatment of laboratory confirmed cases of COVID-19 in hospitalized adult patients. Basically, at the moment, who require some form of oxygen therapy, maybe basic oxygen therapy, or maybe advanced like ECMO and mechanical ventilation. Dose 4 mg once a day for up to 14 days, or if the discharge is earlier, then you stop it. You can give it either orally, or you can also give it to patients got a PEG feed or RT feed. You can dissolve it and give it enterally in them. What is the clinical evidence? There's a couple of papers I will discuss. So this was a classic paper in Anijam by Khalil. It was a randomized study and more than 1,000 patients, multi-center study. Confirmed laboratory confirmed cases with either radiographic infiltrates or requiring mechanical ventilation oxygen therapy. Half received remdesivir or baricitinib, and half received remdesivir plus placebo. What did they find? The primary outcome, time to recovery was 1 day shorter in patients who received remdesivir. Mortality was 5.1% versus 7.8%. Hazards ratio was 0.65. So significant findings in this randomized large multi-center study. So key secondary outcomes in this patient: 30% higher odds of improvement in clinical status as compared to the control group who received baricitinib. And patients with baseline ordinal score of mode 6, so sicker the patients, more likely they were to benefit with baricitinib plus remdesivir. Adverse events, well, the placebo had more adverse events. And if you look at the adverse events, hyperglycemia, anemia, lymphopenia, pulmonary embolism, and so on, they are all complications of COVID-19 itself. So I'm not convinced that they were because of baricitinib as such. And there were no serious, with most of these immunosuppressants or immunomodulators, you think about secondary sepsis, which was not so in any of these patients. So baricitinib plus remdesivir was superior to remdesivir alone, had a faster recovery time, and accelerated improvement in clinical status of the patients, particularly those receiving high flow or non-invasive ventilation with few side effects only. Then this was this paper, co-barrier paper. Marconi was the first author. Again, baricitinib plus standard of care for hospitalized COVID-19 patients. It was randomized, double-blind, placebo-controlled, 4 mg once a day plus standard of care. And standard of care was, since it was a multinational study, standard of care was whatever your guidelines of the particular nation was. So 1,500 patients, 79% of patients mostly received dexamethasone and remdesivir in 20% of the patients. So primary endpoint was proportion of who progressed to worsening of the disease, or secondary endpoint was all-cause mortality at 28 days. So 28 days all-cause mortality was 8.1% versus 13.1%, significant reduction, 38% reduction in mortality. And although it was seen in all severity of the disease, it was more pronounced in patients who were at high flow oxygen or non-invasive ventilation. Those sicker patients benefited more. And the similarity was, adverse events was similar between the two groups. So based on these particular two studies, excuse me, FDA had already FDA approved it as an emergency use for as a monotherapy for COVID-19. What are the guidelines, various guidelines which recommend? IDSA guidelines, the recommendation 16 is among hospitalized patients with severe COVID-19 who cannot be given corticosteroids because of contraindication, we suggest baricitinib with remdesivir rather than remdesivir alone. Again, low certainty of evidence, conditional recommendation. And daily is 4 milligrams per day for 14 days or until hospital discharge. The benefits of baricitinib plus remdesivir for patients on mechanical ventilation are uncertain. So here where it is fits it, as you can see in the later part of the disease, baricitinib fits in quite nicely when the cytokine release is there. So basically, baricitinib is a reversible JAK inhibitor with selective inhibition of JAK1 and JAK2. ACT2 trial, baricitinib plus remdesivir was superior in reducing the recovery time, accelerating improvement in clinical status, particularly in patients who received high flow oxygen and non-invasive ventilation. It was well tolerated without any serious side effects. Can be useful addition for treatment of moderate to severe, for moderate COVID-19 patients in combination with remdesivir. So again, these were the findings of the ACT2 trial. It was well tolerated and is a useful combination. So thank you very much for your attention. And I would like to now hand over the mic to Dr. Sanchit is presenting or Anup Warrier is presenting?
Dr. Anup Warrier, sir.
Okay. So you can, yeah.
Give me a moment to share the screen.
Yeah, yeah.
Good evening. So I will take next maybe 10 minutes or so to dig a bit more deeper into the data. Dr. Mehta has already given you an overview of major trials and the guideline recommendations. So my idea is to clarify on bit so that the positioning, like in which group of patients in our daily day-to-day practice we should implement this as a practice or a standard of care. I'll try to illustrate on that. So very quickly, just a brief look at JAK inhibitors overall, then the review of scientific literature for baricitinib in COVID, the IDSA FDA guidance, we have already seen it in Dr. Mehta's presentation, so I will not take much time on that. Bit of special patient groups where we have data specifically on baricitinib. There is some publication in this month, August 2021, which is a sort of a summary of all the evidences which we have for baricitinib. So it will be important for us to look at that. I will also share the ongoing major trial info, which is still not published, which is ongoing, and we'll look at what that is looking at. And finally, summarize with the key takeaways. So two meta-analysis I wanted to share with you. First meta-analysis was published in, the data analysis, though it was published in 2021, the studies are relevant only till December 2020. So we are talking about 6 months before. So even as early as December 2020, we had systematic review and meta-analysis of 5 studies from more than 1,000 patients where the mortality benefit was demonstrated for JAK inhibitors. So that was the starting point of developing confidence and initiating trials, further trials on these molecules. Between this December 2020 and July 2021, or another 6 months of data, we had 3 randomized controlled trials, 3 RCTs, looking at 1,363 patients, again, which showed mortality benefit for all the 3 kinds of JAK inhibitor. There are 33 kinds of molecule, and for all the 3, they showed mortality benefit. But the safety data was shown to be best for baricitinib. Drsanjith is obviously the other commonly used JAK inhibitor. If you look at the trials which were ongoing in May, so this is a list. So we had about 6 major trials, proper randomized and 1 or 2 non-randomized trials, which were going on in May. All of them looking at baricitinib in various patient groups. So starting from a mild with steroids, without steroids, in combination, and as alone. So multiple kinds of trials were going on at that time. So based on the review which was completed till 30th of May, it was summarized that the baricitinib should be used in combination with remdesivir in non-intubated patients who require oxygen supplementation. So that was the evidence at that time, and at that time the co-barrier study was not published at that time. Okay, so the first recommendation for baricitinib came in such a way, saying that 1, it should be used with remdesivir; 2, it should be used in people with oxygen supplementation; and 3, it should not recommended for intubated. So it was for non-intubated patients. So high flow, low flow, non-invasive ventilation, and all. So that was the placement at that time. And they are given option of using baricitinib vis-a-vis tocilizumab, which was much more commonly used at that time. So now coming to the key trials which were published beyond this, and a little more info on that. So Act 2, Dr. Mehta has already reviewed this very briefly. So it was a placebo-controlled trial, 1,033 patients, 67 centers in 8 countries. The dose was 4 milligram a day for 14 days or until discharge. So the primary endpoint was improvement in symptom scale, ordinal symptom scale as per the WHO, but it did not show much difference in that. So there was not much actually statistically significant difference in the primary endpoint of improvement of symptom scale, because it was just 7 days versus 8 days. However, on subgroup analysis and on overall review, the secondary endpoint of 28-day mortality was significantly better or statistically significant with baricitinib. So that was the key takeaway here. And when we look at which patients benefited out of this mortality benefit, it was those who were on NIV or high flow oxygen at baseline. Okay. So that was the summary of Act 2. The co-barrier study was another multi-centric double-blind RCT. So here initially they included all COVID pneumonias with at least one elevated inflammatory marker. But later the protocol was modified and they excluded all patients not requiring oxygen. Okay. So here again, the whole trial is primarily focused on patients requiring oxygen. So the patients not requiring oxygen were in fact excluded from the protocol afterwards. So 103 centers, 12 countries, 1,525 patients. The primary endpoint was again disease progression to requiring high flow oxygen, NIV, ventilation, ECMO, or death. So any kind of disease progression was the primary endpoint. Here again, strangely, there was no statistically significant difference in the primary endpoint, but again, coming back to the 28-day mortality, which was a secondary outcome here, it showed significant difference. And the confidence interval, please look at the confidence interval, it is 0.41 to 0.78. So that is quite supportive and it gives us robust confidence in going along with the statistical data. The subgroup analysis showed that the maximum mortality difference was in patients who were on NIV and on HFNC. And this was seen across the group of patients with different types of co-administration of drugs. So some of them are on steroids, some of them are not on steroids, some of them are on remdesivir, some of them are not on remdesivir. But irrespective of what was the additional drug, steroid, no steroid, remdesivir, no, the mortality benefit was consistent across when you added baricitinib. So we also have an Act 4, which is again a multicentric double-blind study, which was a head-to-head comparison between baricitinib and dexamethasone. Here, the primary outcome was progression to mechanical ventilation or death. This was prematurely stopped because the interim analysis showed that it could not possibly show any difference in outcome when you compare vis-a-vis dexamethasone. Okay. So 3 messages from the 3 major RCTs, one which was stopped prematurely, Act 2, co-barrier, and Act 4. Both the major completed RCTs have their weaknesses because if you remember, the primary endpoints were not met. It was on subgroup analysis and secondary endpoints, but they definitely show which group of patients might benefit from baricitinib. That's the indication it gives us. So based on that, patients on low flow oxygen to HFNC, the co-barrier, they took all patients on oxygen, all patients from low flow to HFNC. So patients on low flow oxygen to HFNC are the target population, irrespective of whether you're using steroid along with it or remdesivir. And the Act 4, which was stopped prematurely, gives us a message that it cannot substitute DEXA. On head-to-head comparison, if the patient needs DEXA because of hypoxia, you have to give DEXA. You can't substitute this. The IDSA June 25th, 2021 update, Dr. Mehta has already shown this, just to highlight that at that time, they showed that it was not recommended for those on invasive mechanical ventilation, okay, based on the published data till May, right? I have shown you the published data till May. and they focused it on high flow oxygen and non-invasive ventilation at baseline. The FDA, however, after the publication of the later trials, which I showed you, that is the co-barrier and other studies, and there are a couple of other data which I'll show you in the subsequent slides. So they told that all patients on oxygen requirement, including ventilated and ECMO, they gave an approval. So if you look at the scope of authorization, the Baricitinib covered by this authorization will be used for our adult and pediatric patients above the age of 2 years requiring supplemental oxygen, non-invasive, invasive mechanical, or ECMO. So at all grades of oxygen requirement, the FDA has approved this for use. Now, a couple of short studies on special patient groups. So this is a patient group of critically ill, very severe critically ill patients with significant respiratory distress. And obviously somebody with significant respiratory distress would be on steroids. And in this group, 43 patients, it showed a survival of more than 90%. Okay? And look at the mean age, it was 70. And look at the male gender preponderance, 70% male. So these are the worst patients. We know males have higher risk of mortality. We know elderly have higher risk of mortality. We know the patients with respiratory distress have higher risk of mortality. So they tried it in the worst possible scenario and they showed that they have a favorable outcome. So this is something which is encouraging. So this is another study which looked at one of the fears which you have, that if you give it along with steroids, will it increase significantly the infection risk? So here it was 197 patients in two groups, where one they gave Baricitinib plus Dexa and other Dexa alone, right? So you don't substitute Baricitinib for Dexa. Act 4 has shown that. So Dexa alone versus Dexa plus Baricitinib, and in this they showed that it did not increase mortality risk, and adding Baricitinib to dexamethasone reduced mortality significantly. Look at the number needed to treat. It was just under 5, extremely good number needed to treat. This is a third patient population, a patient population who is elderly. So specifically on elderly patients, looking at safety issues because of their concomitant medication use, adverse events, drug interactions, etc. So here again, they noted an absolute risk reduction of 18.5. All of them were above the age of 70, significant reduction in mortality with no safety issues. So this is the final concluding slide from the data review. This is published on August 4th, current opinion critical care. Summarized data from more than 3,000 patients in randomized control trials. More than 3,000 patients in randomized control trials. No major safety issues identified. Primarily, they looked at secondary infections and venous thromboembolism as significant safety issue. Okay, so these are, when I talk about safety issue, these are the two which I'm thinking about. With significant reduction in 28-day and 30-day mortality demonstrated across all the studies. This is this trial which I told is ongoing, which is still not out. This is a part of the recovery. So the part of the recovery trial, they have included Baricitinib as an early immunomodulation arm, where they are trying out in patients without oxygen support, right? Till now, all the data which we saw was patients on oxygen support or elevation of inflammatory markers, etc., etc. So here they are using it for patients without oxygen support or without looking at inflammatory markers, and they are giving it for a shorter duration. The other trials, it was for 14 days. This is for 10 days or until discharge. And the beauty of this trial is that once this comes out to be, this is going to be adequately powered to show mortality benefit because it's such a large trial. So to summarize and to help us gain clarity on where you want to use the drug standing today, first, we need to remember it is not a standalone therapy as a substitute for steroids for immunomodulation, right? Because Act 4 has shown somebody who is on hypoxia and requires significant immunomodulation, steroid is indicated, head-to-head Baricitinib failed. So not a substitute for steroids. 2, it is indicated for patients on oxygen supplementation as of today. Why a recovery trial is still not out. So until now, patients on oxygen supplementation, all levels of severity. We have data across the spectrum, starting from low flow oxygen to ECMO, along with standard of care. So you continue with what is the present standard of care, be it remdesivir at that stage, be it steroids at the stage, and you just add Baricitinib to it. Excellent safety profile, including when you give it along with steroids. Okay, so that has been demonstrated across the studies. Meta-analysis show mortality benefits across the recommended population, but the best effect was seen in moderate to severe COVID. Okay, so that is the reason oxygen supplementation, we are picking up that group of patients. We have specific data on elderly and ICU patients for safety and efficacy, because we need to look at the drug interaction profiles and other parts when you look at this population. And the last recovery trial data, which is awaited, and we will look at what it shows whether we want to use it for non-oxygen dependent patients. Thank you.
Sir, you are on mute. Sir, you are on mute.
Dr. Sridharan, I think we'll get on with your presentation and then we'll have the panel discussion.
Yeah. So, am I audible?
Yes.
Yeah. So yes, we did meet a while ago when we were actually talking about Baricitinib. Sir, I remember that day when I told you that all those patients who were getting consulted, video consult long ago, and who could not get to the hospital and was taking oxygen at home, this is the drug that I used on a regular basis, and my experience actually started from there. Yes, as doctors and scientists, we are searching. As Van Gogh said, this is how we look at it. We keep going till come what may, and we should be at the end of the spectrum. We should probably get something. And we started with at the start of 2021. We started with the evolution of steroids and monoclonal antibodies. Steroids was rather broad on the immune suppression, rather broad, and monoclonal antibodies were actually targeting a very, very narrow spectrum, a single pathway. So we had something that was very broad, very good, that is very broad, which has been proven as of now, and a monoclonal antibody that is targeting a single pathway. So these were the things that we came up till 2022. Well, what if we had something that had fewer, that inhibited fewer pathways than steroids, and a little bit more than the monoclonal antibodies? And I think the answer to that is probably the rise of the JAK kinase inhibitors. I think that's where it stands, somewhere between extreme pathway inhibition and just above the monoclonal antibodies. And I think it's just safe enough, really speaking, because many trials have gone ahead and said, more importantly, all the things that we talked about, lymphopenia with Baricitinib, has been kind of disproven, because although lymphopenia is generally considered a contraindication to the use of Baricitinib, most of the COVID-19 patients' lymphopenia actually goes up once you start Baricitinib. That's what all the trials have said. So it's actually looks like an indication to use Baricitinib rather than actually not using Baricitinib. The other thing is neutropenia, but we don't see so many neutropenia in COVID-19 patients. And the third thing is anemia. I think that would occur only if you're going to use it for a long period of time, as in rheumatoid arthritis. This we're using for barely 10 days. So this will not probably cause any kind of anemia, is what it looks like. Very clearly, all the studies have actually said the same thing. And this is also thinking about DVT. But if you look at the patient years, is 0.6 per 100 patient years in rheumatoid arthritis studies, and that also those patients who had lymphopenia. This is going to cause the lymphocytes to go up. And Rodriguez-Garcia study, which is presented, actually showed that it actually the DVT risk goes down. Moreover, most of our patients who come into intensive care, all of them get almost intermediate to therapeutic dose of Clexane. So I don't think so. This is a major risk. So there are animal studies that say it doesn't really reduce viral titers like the way it actually does in theory. There are animal studies, but it seems to prevent the immunopathological progression, is what it looks like. So what if it doesn't reduce viral titers? It probably prevents the immunopathological progression that we normally have in these cases. So let's dive into my experience. I'm glad I removed all those slides in the middle, because I had so many slides of that already Sir and Dr. Warrier has already presented. I'm just diving into my experience. This is not really a complete entire thing that I've done. Let's just dive into what I had. I had 86 cases, and I told one of my residents to just pick up 30 odd cases now and 30 odd cases at a time when we didn't use Baricitinib. Likelihood is that this entire population is one population in our ICU. All those patients who came into the ICU, we actually have 100% use of Baricitinib in all our patients that get into the ICU. These are 30 patients now and 30 patients from a previous time, and we compared largely the same group of patients who were admitted, a complete mix of HFNC requirements, NIV requirements, and ventilation. And what we found, at least in this study, is in what our data was, length of stay definitely came down. Length of stay was definitely down in non-ventilated patients, especially those who were on high flow nasal cannulas, helmet CPAPs. Their length of stay definitely came down. It's a good number came down. It was even getting better when you looked at ventilated patients rather. In fact, more severer they were in those patients when we started it early. They seem to be actually doing much better among those patients who were ventilated, very clearly a big change in the number of days, somewhere around 7 or 8. I couldn't believe it when I actually saw this data, but it kind of mirrors whatever we just now heard in the recent past. And on days on ventilation also, I mean, that is something that is very significant for me in my ICU, because when we are on ventilator, we have around 1:2, when we're running nurses, 1:3, 1:2, it comes to 1:2 when the patient is on a ventilator. So the moment the patient gets liberated from the ventilator, very quickly we get more nurses working around. So this becomes a very important figure. It actually comes off the ventilator much quicker, and we avoid tracheostomies. I mean, in the past we were doing so many tracheostomies, but now since the last 3 odd months, our tracheostomy rate, 4 odd months, the tracheostomy rate has actually come down majorly. We are able to get them off the ventilator, many of them, much quicker than what it was earlier. So I feel baricitinib, in Punjabi we call baricitinib bari as a window, right? So I think this probably is the window to our success, I feel, as of now. And it seems to be doing quite well. I don't have any kind of secondary infection related issues. In fact, most of the studies have actually said the infection rate actually comes down. Thank you very much, and it'll be glad to have the experience of all my esteemed colleagues.
Thank you, Sanjith. Very interesting findings, reassuring. I think we can now, let me see if there are any audience questions, but I have a question for Sanjith to begin with.
Sir.
That, I mean, at the moment, it is not recommended by any guidelines for domiciliary patients, non-hospitalized patients. You did use it for non-hospitalized patients. Although I would think that the requirement for hospitalization definitions changed during the second COVID, because patients who would require hospitalization, who would normally be hospitalized, were not hospitalized because non-availability of beds. So would you like to comment on?
Sir, you have actually answered my question. These were patients who were actually at home, required hospitalization, didn't get beds, and they were hooked on to oxygen. And these were those patients who were organizing cylinders at home, keeping concentrators at home, and they actually required hospitalization. But just because they didn't have beds, they were struggling. And the drug that was easily available there was steroid and Olumiant. The Olumiant is Baricitinib, which was available very easy, very cheap drug. And we actually used those drugs. I was very skeptical the first time because only the Act 2 had come out at that time. So I was very skeptical, but I started using it because there was no other way to get these, get to the hospital, and I achieved a huge amount of success because of, I think probably because of steroid and baricitinib. Yes, you're right, sir. There is no indication in domiciliary care, but these were actually kind of indications because of the fact that they weren't getting hospital beds.
Yeah, same thing would apply that people who remdesivir is recommended only for hospitalized patients. But many patients were getting hospitalized because they wanted remdesivir. They didn't require hospitalization. So that changes. The whole thing was very fluid. I mean, all these guidelines were thrown out of the window because of this changing, supply and demand thing which happened during our times. I mean, okay. Now,
Dr. Mehta, sir, Dr.
Yes,
Reshu Gupta ma'am has also joined, just to share.
Yeah. Okay. So, Rishi, welcome.
Thank you, sir.
All right.
I think my name is showing as Nivans. I'm so sorry for that.
No, that's
I just logged into my son's.
No, it's nice to be recognized by your son rather than a son being recognized by you.
Absolutely,
That's
absolutely.
Yeah. All right. So now, see, I'll open it to both of you. I think you can begin with you, Reshu. That which combination would you use? Would you be happy to use it with steroids? Would you be happy to use it without steroids? And you have to use remdesivir along with that? Tell me now, what is your
So what we are doing here in our setup, sir, we are using Baricitinib in patients where, as Dr. Sanjith had mentioned, where we have the patient is on oxygen. So if the patient is on oxygen, then the patient is on steroids. So usually we have been using as a combination with steroid, remdesivir, Baricitinib, all three. And till now, yes, we are quite satisfied with the results. We are keeping our record. Till now, we have not published anything, but yeah, we're keeping our records and it's not that bad. So we have not used, initially in the ward, they had started using the physician in wards, they were shifting, but it was not that effective. As Dr. He has mentioned in domiciliary care, So I did not happen to do any, or I did not, in our unit, in our state, we did not get that scarcity of beds as of yet. So we were using in only and only hospitalized patient, not as domiciliary patient, not at all. And
Yeah,
with
see,
steroids, with remdesivir.
yeah, so remdesivir, steroids in hospitalized along with
Yes, yes, along with baricitinib.
Yeah, so obviously you will not be able to use it if you are using domiciliary sort of thing. Then obviously you will not be able to give remdesivir along with that.
Exactly.
Yeah. Okay. And Dr. Warrier, any comments on this?
Yeah, so if you look at the combination and if you look at these three drugs together, so let me start with remdesivir. So remdesivir has got a window period, right? So most of the data and some of our state guidelines also, they recommend that you restrict the use of remdesivir to the first 7 to 10 days of onset of illness, right? So once that first 7 to 10 days of onset is done, the remdesivir goes out of the mixture of drugs which you are using. So if the patient lands up with oxygen requirement within the first 7 days of the illness, then all three go on board. So you need to give remdesivir because it is first week of illness. You give steroids because the patient is hypoxic, and now you add on baricitinib. But beyond that, 7 to 10 days, remdesivir goes out and the patient is on baricitinib and steroids. So that's how it works in my setting.
Absolutely.
Yeah, yes,
Agreed.
that 7 days can be extended to 10 days, but that's the max you can extend for remdesivir.
Remdesivir. True,
Yeah.
sir.
Okay. And what about use along with tosi?
Oh my God.
I'm just asking.
No.
I think we have enough of immunomodulation with steroids and baricitinib. And in fact, the earlier one of the studies which I showed you published in May 2021, and the summary was that it actually forbade combination because of risk of very prolonged immunosuppression, which could be severe and raise the risk of secondary infection. Because tosi has shown that it is associated with more significant secondary infections with steroids, and also the half-life is long, the immunosuppression is much longer. So since the data with baricitinib steroid is so good, I don't think tosi, I'm going to mix it up. Again, the placement of tosi would be when you are already on all this and then there's a sudden deterioration, right? And you want to catch at the right moment. But still, it's a very fluid recommendation.
So what will I agree with you that obviously use tosi, suppose you give tosi along with it, the secondary sepsis will go up significantly. But suppose the IL-6 levels are going up, the patient is deteriorating, and you think about using tosi at that point of time, what will you do? You'll stop baricitinib and give tosi, or you will not give tosi at all?
So I would probably give tosi at that time and stop baricitinib, because at that time it will just give us 24 to 48 hours. Then the patient is gone. So if I give to tosi, I have to give it then.
So that is what makes sense. Yeah, in that situation, you would stop baricitinib and then still give tosi. I think I agreed with that. Although baricitinib also, for more severe the disease, the benefit is more significant. The mortality benefit and the ventilator-free days, which Sanjith also has shown that it is significantly less.
Remember that in both the large trials, it did not prevent progression like tosi did. The beauty of tosi was that it was something that you give and prevent progression. It was something like that, rather than later this. So baricitinib did not have that kind of that kind of effect. It was not like that. So you have somebody rapidly falling, tosi is the way to catch them.
See, tosi is also not that wonder a drug, actually, to be honest. See, I have one of the authors of that study in Lancet Respiratory Medicine, randomized Indian trial on tosi, moderate to severe COVID-19. And in the primary endpoint, we did not meet the primary endpoint. Only in subgroup analysis, we found that there was some evidence that in the more seriously ill patients, which the numbers were less, there was some benefit. So tosi, yes, one should use tosi, but secondary sepsis does go up. I mean, when we were rampantly using tosi, in most of the patients, the secondary sepsis really went up. I mean, we saw not only fungal sepsis, we saw so much of candidemia and other organisms, Morganella and Cenotomonas and Pseudomonas, which we never used to see in ICUs, has all appeared during this time, I think, because of high dose steroids and tosi combined together, I suppose. That we went through all that. Side effects, any of you have seen?
Of Baricitinib.
Yeah.
So
I
first
think-
of all, I don't think there is any free lunch when you're actually using Baricitinib. You have to be very careful in the first place. Everything relies on secondary infection and hand hygiene, most importantly, which definitely went down. But it's a little bit more complicated, I feel. I have a feeling that what happens with Baricitinib is it doesn't just get on the pro-inflammatory phase, it also prevents the CARS phase. I think it prevents the immune paralysis towards the end. And that's probably the reason that it keeps the infection under control. Immune paralysis doesn't take place too much, is what I feel in Baricitinib. Like tocilizumab, you rightly mentioned, sir. You give tocilizumab, the immune function goes so badly down that you start getting secondary infections. I have not really noticed secondary infections with Baricitinib. Whether it's an improvement of the hand hygiene or whether it's a Baricitinib doing it, I'm not very certain. But I can vouch for the fact that Baricitinib did reduce the days on ventilator and it prevented many of the intubations, and probably that's the reason also the ACT2 showed reduced infections compared to the placebo, because those patients who were ventilated had usually secondary infections, whereas those patients they on Baricitinib had very less amount of intubation and ventilation. So probably that might be the reason that Baricitinib actually reduces reduces infections here.
Yeah, so it was much less than placebo. I mean, worries about sepsis, but it was less than placebo. I think one of the, I just hypothesize that one of the reasons may be that, see, all of us have a tendency when the patient is not doing well, increase the dose of steroids.
Yeah.
So that maybe prevents it. If you're giving Bari, that suddenly you may not have to do that. You will continue with low dose dexamethasone, whatever you're giving. What about the duration? 14 days is normally the recommended, or the patient gets discharged earlier. So 10 to 14 days is what is normally. How long you use it for, Sanjay?
So I've used it for, I have a fixed protocol in the hospital. It's 10 days of Baricitinib and 10 days of steroids. That has been fixed in the hospital. So we are giving 10 days of Baricitinib. We were in the COVID steroid trial. So I had not much of a leeway. There was 10 days exactly. We had to stop the steroid. It was like that. So it's been like that and it's not changed. We have never gone more than 10 days on Baricitinib, though I don't think there will be a problem if we go till 14 days. But we have till now not gone to 10 days. We have not gone beyond 10 days. In fact, many a times we've rather stopped it at 7 days because patient has miraculously done so beautifully well that we've stopped it at 7 days only. Many times.
Dose adjustment in the renal dysfunction?
2 milligrams if it is less than 30. Otherwise, less than 15, we don't give it only.
And children, you can give 1 milligram, 2 milligram, depending on the.
Yeah, children. That is one thing that has come from Baricitinib. At least we have something to give the child. It's like that.
If the patient is on RRT, then it's not recommended. I think generally Baricitinib should not be used to patients on RRT. Anything, Dr. Warrior?
So in this acute kidney injury RRT setting, do you use tofatinib instead of Baricitinib?
Absolutely no way to understand whether tofatinib, how to give it, what to give, no experience. So it's either Baricitinib or nothing. It's like that. At least on the JAK2.
Reshu, any comments?
So same, we give Baricitinib for 10 days fixed and steroid for not more than 10 days. So it's always a fixed dose for 10 days and after 10 days we stop. I just would like to say, sir, regarding the tocilizumab, the discussion we were having, I think the timings in this COVID pandemic is very, very important. Timing of the drug administration when we are giving, and we have a fixed rationality for that. So the timing, like as Dr. Sanjith had mentioned, that within 24 to 48 hours, we have just that window period. If given, it works. If not, it won't. So we'll land up into more of secondary infections, as you had mentioned.
Guided by what? Clinical deterioration or any biomarker?
So actually what we do, we do not wait for only IL-6. We just see the clinical deterioration, and if there's a sudden rise in the D-dimer, CRP, those are the parameters we just wait, because IL-6 many a times it was a very false guide for us. Many a time. So IL-6 on the basis of only IL-6. Yeah, and on the basis of IL-6, we did not wait wherever we have used tocilizumab.
Yeah, I think D-dimer, maybe CRP can be a good guiding factor for
and
a sudden jump
and clinical deterioration. Absolutely, sir.
Any other concerns about use when you would not use it?
So the tocili or Bari?
No, Bari.
We do not use it, and we have not used it when the patient does not need oxygen. In mild cases, no, not at all. Again, in severe cases also, patient after, even if patient have not improved after 10 days, we do not continue, sir.
I think even liver dysfunction, significant liver dysfunction also, one should not use it.
In only renal dysfunction, we just reduce the dose, as rightly said, to 2
And
milligrams.
RRT, you
Severe
don't
liver
use it.
dysfunction,
That is what they say.
no, no.
75% is excreted unchanged in the urine, actually. So that is okay.
Liver, sir, liver, I feel, sir, liver, I think hepatic toxicity is possible with any drug, I feel, sir. In fact, when you look at Act 2, in the amount of liver enzyme elevation was so low, it was hardly 1.2, 1.3. In fact, that was one of my drivers. Act 2, I know to try inside out because that was my driver for Baricitinib, at least in my care, in my patients. So I studied that trial so much that the amount of AST, ALT elevation was only 1.3, 1.4%. So yes, if it is elevated in the starting, then there is no point of starting this drug. It may create problem in ladders and soup actually, but I think it doesn't cause it per se. Yeah, it doesn't.
Yeah, even with favipiravir, people who have used favipiravir, only if it crosses 5 times the liver enzymes, only then they would stop it. Otherwise, people are continuing with twice or 3 times normal. Most of the times it settles down. So liver dysfunction is not really that major an issue with most of the serious COVID-19 cases.
Sir, in fact, you know what? I feel this drug is beautiful because I was always worried about lymphocyte count, always worried about lymphocyte count in COVID-19. And it used to mirror the deterioration. If the lymphocyte doesn't go up, the patient used to actually deteriorate very badly. But what happened with Baricitinib coming in is when you start Baricitinib, within a few days, the lymphocyte count actually goes up quite quickly. In fact, I do not know whether there is a real relationship of Baricitinib lymphocyte count, but it does cause it to go up quite quickly. And that's what many of my data is actually telling me this.
That's an interesting finding. See, the multiple studies have shown that neutrophil to lymphocyte ratio predicts mortality in patients with COVID-19, but the lymphocyte count goes up. That's a good sign for immunomodulation and patients' response to the viral infection. So and I think few experimental studies have shown viral replication is less with Baricitinib. As I showed in one of my slides, endocytosis is reduced with Baricitinib because certain proteins which are affecting the entry of the virus into the cells. So I think that may be helpful from that point of view. Any other concerns?
So has anyone tried more than 4 milligrams of Baricitinib in any study, anytime?
Not that I'm aware of. Dr. Warrior?
No.
Okay.
No.
If 4 works, does 8 work?
That is a standard. And the drug is not that expensive. See, I think that is also another thing. So your thing, actually, I have been thinking about it. It's so much easy to give it orally. No, any medication to give. That is how favipiravir was marketed. Because you can give it to a patient at home, rather than admitted where you give remdesivir. So that was a differentiating point. So that may be applicable in this sort of situation if the patient is on domiciliary oxygen. Oxygen because of COVID-19, not because of pre-existent pulmonary disease. I think that does make sense. So
there's a patient in my ICU who's got myasthenia gravis, and he has COVID, and he was on azathioprine when he presented to me. He's not an active myasthenia as of now, no crisis per se. Now here I was, I really didn't know what I should be doing. He is not presently on a ventilator. His muscle diaphragm and all is working very beautifully. External intercostals all okay, no lid drooping, nothing like that. So here I was completely flummoxed as to what I should be doing. Should I be, because my practice was steroid and Baricitinib. Now suddenly this patient comes inside and Azoran remains in the body for like months, 1 or 2 months. So I was just wondering what I should be doing here. I have this patient presently in my ICU.
Yeah, I would be a little hesitant because your patient is on top of that you are giving steroids.
Yeah.
With Azoran and Baricitinib.
No, sir. I have not given Baricitinib. My protocol, I was very scared.
I would not. That's what I was saying. You did the right thing. I also would not give it.
So, but sir, now what happens is if he goes into, say, a crisis or he goes into, say, a storm, I'm not aware. If he goes into a storm, now I think what should I use here? Is it going to be Tossi or what is it going to be? Because see, Baricitinib is, it's a difficult thing for me because my doctors will look at me and ask me what is to be done. I don't know.
Yeah, that is true.
I don't know what to do.
Difficult
So
question.
what would you do, sir, in this case? Say this patient was in your ICU, just ventilate and wait, or would you use pharmacological therapy in any way?
See, I may use now this is off-label users, but I may use urinastatin. I may use a cytosol. IL-6 levels are very high.
Yeah.
And that doesn't affect that doesn't produce immunosuppression. It will just modulate it. So I may do that.
Right. So I'll keep that in mind, sir. If this patient goes bad, I'll probably just start him on a cytosol, which is much more easier to do for me.
Yeah, true.
Yeah.
Most of the Anything else? Any questions from the audience? I don't see any questions from the audience. So I think everybody seems quite convinced that you should be using baricitinib in these sort of cases. I think both of you have presented it quite well. So I think I've enjoyed the presentations and the discussion. So if there is nothing more, I would like to hand over the proceedings to the CIPLA team.
Okay, sir. Thank you. So most of the doubt might have get cleared during your discussion also. It was very knowledgeable and fruitful discussion. So, sir, on behalf of CIPLA, I would like to thank Dr. Yatin Mehta for his excellent moderation, and also panelists Dr. Sanjith Sashidharan, Dr. Anup Warrier, and Dr. Reshu Gupta for sharing their clinical experience and opinion about baricitinib. And lastly, I would like to thank all the attending doctors for sparing their time and attending the session. Thank you all.
Thank you very much. Bye-bye.
Thank you, Sanjay. Thank you.
Bye.